Perfect. Lovely. I'll hand over to you, Alison.
Thanks very much, Lily. And for those of you who don't know me, I'm Alison Tavaré. I'm a GP by profession, but I've got a portfolio career, and I'm also a primary care clinical lead with Health Innovation West of England. And I co-lead the South West Learning Disability Collaborative. And in addition, I'm a clinical coordinator at NCPod. I'm going to talk today about how NEWS2 can help me identify the unwell patient, as I have a special interest in deterioration, and particularly in the use of news. Next slide, please. So hopefully it'll come through in a minute. And so what I'm hoping is that by the end of today, you'll know a bit more about NEWS2, how it can support you in clinical practice and clinical judgment, and improve communication across settings. And very importantly, learn about the evidence for the use of news in non-acute settings. And I've chosen to use lots of practical case studies to help illustrate these points. Next slide, please. So usually I would, sorry, I'm going to have to cough. Sorry, just getting over whooping cough. Usually I'd have a show of hands to see what people know about news. So this is all anonymous, but it's just so, have you actually heard of NEWS2? So yes, no, or not sure. Oh, brilliant. So far, 100%. That's fantastic. It just means that sometimes, and obviously much less, people don't know about news. But the fact that 100% of you do know about it means that I can slightly move over those slides. Thank you. And then the next question, please. Lily, the next slide, sorry. If so, do you regularly use NEWS2 in your clinical practice? Okay, yes, 60%, okay. That's really good. So about 2/3 use news in clinical practice, perhaps 50%. So that's great that a lot of people are using NEWS2, but it's also helpful that a lot of people aren't. So it helps me understand what's happening. And so if you want to ask more questions, I will be taking questions at the end, but please put things in the chat so that we can address them for you. But that's really helpful. Next slide, please, Lily. So since I know that you all know about news, I won't say too much about it, but obviously it was developed by the Royal College of Physicians to standardise the assessment of the acutely unwell patient, and just is based on the 6 simple parameters. And what I think the beauty of this is it doesn't need any special kit or tests. It's stuff that we've always done in primary care and community settings. Next slide, please. And so how can NEWS2 be used? So first of all, it can be used for clinical acuity. So the higher the news, the sicker the patient. It can also be used as a track and trigger score. So if you measure the news now and then measure it again, if it goes up or down, you can work out if a patient's getting better or equally if they're deteriorating. And finally, it can be used as a clinical response as a common language. So I've got a patient with a news of 4, yours has a news of 6. Then that means that your patient with a news of 6 is likely to be more unwell. So those are all the ways it can be used in secondary care, which is where it was developed. But I feel that all those uses are relevant in primary care, and often say it's the same language but with a slightly different accent. Next slide, please. The news was the original one. It's been more recently been adapted to NEWS2 in 2018, and that was to address the problem with people with long-term lung conditions who had low oxygen saturations as abnormal, and so they would trigger an alert. So Scale 2 addresses that. I won't go into it in more detail, but there's just some information there if you'd like to know more for patients who have hypercapnia. But by and large, most patients that we see have Scale 1 are on Scale 1. And if you don't know, use Scale 1, because patients who've got hypercapnia will be asked to let you know. Next slide, please. And so I said the higher the score, the sicker the patient. And so the RCP recommend that anybody who's got a news score of 5 or more thinks sepsis. Next slide, please. So what's been interesting is there's more and more evidence coming and being developed on the value and use. And I thought this paper, which Howard had shared with me back in April, was really helpful. It was One of the authors is Adrian Boyle, who's the president of the Royal College of Emergency Medicine. And when I presented with him at the Royal College of Emergency Medicine talk back in 2018, and he wasn't that sure about the place of news in primary care settings, and he's really changing now. And this is 80,000 first news twos on the arrival at ED. And if you look at it, on the left is all the news, and then it gives you the outcomes. And basically, the higher the news, the poorer the outcomes. And the mortality is kind of 26% if the 30% if you've got a news of 9 or more, which is actually quite significant, really has impact. Interestingly, that patients who didn't have a news score recorded also died. And I spoke to Adrian about it, and he said that this fits with a lot of the problems that we don't recognise sometimes, that patients are sick. So they don't recognise somebody's sick, don't record news too, and therefore the patient still can actually die because their illness hasn't been recognised by the clinician. Next slide, please. So how did I get involved with news? It was basically because Anne Polyblanc is a surgeon at North Bristol, and she was involved in patient safety and wanted to improve communication at handover. So when the work started, West of England HSN as it was then, the recommendations were that, were only for using news in acute settings. So what the HSN suggested was that as a GP, we would make a decision to admit a patient and then calculate news and share the news with the admitting team. So therefore we had the same value from primary care, go into the ambulances, into the ED, and then into the acute. So that news, the National Early Warning Score, followed the patient. Next slide, please. And in that way, we could help the admitting teams ensure that the patient was seen by the right person and the right place and have the right kind of care. So they were asking for the full sets of observations. And the general recommendations they had were, if a patient had a news 2 of 3, they might be seen in same day emergency care or other alternatives discussed, such as hot clinic. News of 5 or more seen in the ED, and if they had a news 2 of 5, the blue light admission to the ED. So really quite helpful for the admitting team. But very quickly, the GPs using news found actually could help their practice. Next slide, please. And I was one of those GPs who started to find the value of news too. So I was on the NICE guidelines study advisory group for sepsis, and that's when I first learned about early warning scores. And to be honest, I didn't really think that I would use them, because for me they were very much a tool to be used in the acute sector. And then one day I wasn't on call, I was just sitting there over lunchtime sorting out paperwork as clinic admin as usual. And one of the receptionists came and said, "Alison, will you see this woman? She will not leave. She's absolutely adamant she's got to be seen." And she was very demanding. She came in to see me. She was smartly dressed. She looked absolutely fine. So I thought I'd take a history and examine her and then talk about appropriate methods of asking for appointments. She had a very vague history of just feeling rubbish. And I started examining her and thought, there's something going on. She'd got slightly lower SATs, raised respiratory rate, did her news, and it was 5. And I arranged for her to be admitted. And I remember kind of saying, I think she's quite unwell. She's got a news of 5, which I understand is not good news. Could she have sepsis? But she looks absolutely well. And I was quite apologetic. Admitted her, looked at her notes the following week, and she did have sepsis secondary to pneumonia. And there was that moment of like, oh my word, it was odd behaviour. My only regret is this was before I got involved in this work. I didn't write her name down, and I wish could have contacted her, because I wonder if she had a feeling of doom that she was about to die, and that's why she was being so demanding. But that really made me start thinking, actually, I can see the value of news too to support my clinical judgment. Next slide, please. So how does it work in practice? I just thought I'd share this case to kind of give you a bit of an example. And this is one I picked up in the BMJ in 2019. Case of necrotizing fasciitis. I'm not expecting anybody to be experts in it and to know what it is. But this was the article, it was a case review. Next slide, please. And as you can see, these are the observations for this patient shared in the case review. Raised respiratory rate, systolic blood pressure 85, is that significant? They're 49, pulse rate 114, a bit high. So if we were mulling over this patient, I think we'd probably agree they're probably unwell. Next slide, please. And then you look at the Q-SOFA, which was recommended in 2018. It's based on respiratory rate and blood pressure. If we should be using it in primary care, never took off, but that's what was mentioned in this article. Q-SOFA of 2 doesn't help me. And then the next slide, please. And this is using those numbers, this patient had a NEWS2 of 9. So immediately, you may not know anything about necrotizing fasciitis, you may not know anything about this patient, but we know that NEWS of 5 or more, you think sepsis, this patient's sick and something needs happening. And even if you're not a clinician, if you phone the admin team, the reception teams, people know this matters. So I hope that's a helpful kind of way of working through. Next slide, please. So what's happened is I've given more talks, more clinicians have shared stories, and that's why I thought I'd start sharing them with you rather than just giving you some of the theory. Well, I will give you some of the theory and the research later. I've just seen, I've never heard of Q-SOFA in the chat. It was something that we all argued about actually on the NICE guidelines development group, that it was very much a secondary care tool and they wanted to impose on primary care and the GPs. And I know Simon Stockley from the RCGPs on this call, we all said we couldn't see the value. So don't worry, you haven't heard about it. It was one of those situations. So this chat, in fact, came from an RCGP colleague who was working out of hours. Again, a young woman presented very anxious, very vague, and was obsessed with her nails. She didn't look particularly unwell, but the GP took a full set of observations. The woman had a NEWS2 of 6. So the GP arranged for this woman to be seen by the medical team. And within an hour, she collapsed and she was found to have toxic shock syndrome. She'd got a retained tampon. I don't know how many people have seen that, but it's not something you normally ask about when somebody comes in to see you and is anxious. And the marks on her nails were splinter hemorrhages. So the woman was admitted to ICU. And when the GP shared it with me, she said, again, she didn't think there was much going on, but we both wonder whether this woman had this feeling of doom, which isn't uncommon with sepsis, and if that's why she's so anxious. And so one of the things I would suggest to you is that by taking full sets of observations, particularly useful if someone's presenting oddly. Next slide, please. And sometimes it can just help you work out what you should do. So this was shared with a nurse, advanced nurse practitioner colleague who saw this man in surgery, bilious vomiting and abdo pain, NEWS of 9, again sick, a really sick man. So she admitted him. Was it sepsis? Was it obstruction? Actually, for us in primary care, the diagnosis often doesn't matter, does it? We're looking at, is this patient sick? Do they need to be in hospital? And once they're admitted, then you can blue light them into the ED. You can prioritise the ambulance because this patient is sick. And you're not thinking, should they be seen by the surgeons? Should they be seen by the physicians? Get them seen in the ED. And just as an incidental, this man had a respiratory rate of 30, and the more that I've used NEWS, the more I find that's the most useful rate. So I would really recommend, if you don't use respiratory rate, think about measuring it more often. I do it over 15 seconds initially, and if it's less than 16 and I'm not worried about the patient, I'll often record 16. But if it's raised 18, 20, 22, I'm starting to think, what's going on? Next slide, please. And this was shared with me by Matt Kim, who's one of the clinical directors for infection. And as I said earlier, NEWS can be used as a track and trigger score in hospital, but actually we can use it over different timeframes in community care, in the community. This was a woman in her 50s with rheumatoid arthritis on disease-modifying medication. So she was, would have a degree of immunocompromise, Turned up in the morning with a lower respiratory tract infection, NEWS2 was 2. She was appropriately safety netted and antibiotics prescribed. Returned more unwell the next morning, seen by the different GP, and her NEWS2 was 6. So I'm just admitting people. And she was blue lighted into hospital because there was objective measure of deterioration and treated for sepsis. And that to me is one of the uses of using NEWS when we're in different systems and we're seeing patients, particularly with emergency colleagues, paramedics, AHPs, seeing patients in clinics. And then if somebody comes back for review, does that help? Looking at the NEWS, you can track what's happening. How often do you review patients who've been seen by colleagues? And it may be within a few hours or it could be a few days. Next slide, please. So when did we know that our work was our ideas were starting to work? I'd given quite a lot of talks to raise awareness, and John was as a GP in Backwell, and he saw this man who got a history of sepsis from cellulitis. He didn't apparently look that unwell, but he had a NEWS2 of 7. John arranged an ambulance. He was able to prioritise it because of the man's news. By the time the ambulance arrived, he'd got a NEWS of 8. By the time he arrived in the ED, he'd got a NEWS of 9. So you can see that they were able to track the change for this man, but it also supported people in identifying he was really sick. Before he got full treatment, his NEWS went up to 11, so he was really deteriorating very quickly, but he was treated promptly and home within the week. Next slide, please. So I hope that gives you a quick overview of Paul's story, but if you want to kind of look at a video, it's about 5 minutes. Do look at this QR code and have a look at the video, which gives it in more detail, but hopefully you can see where your place might be in the use of news and how it could support your use of clinical judgment. Next slide, please. So you may be aware, you may not, but there's been a NEWS2 patient safety alert in 2018, which is national, recommending the use of news in the acute sector and in the ambulances to support the identification and management of deterioration in patients, because it's been recognised as a patient safety problem that deterioration is often not recognised and the patients have died. Next slide, please. So although the patient safety alert is only for the acute sector in the ambulance, I would suggest it's got a value outside. And so again, I'm going to share a few more stories of how NEWS2 can be used. And one of them, and this has been a real surprise to me for my personal clinical practice, is actually using NEWS2 to support decisions not to admit a patient. And this was shared to me by a colleague. A man in his 90s, he slipped and fell in the bathroom. Wife couldn't get him up and he called for the paramedic. Paramedics got him off the floor and, apologise, I'm just admitting that people. And they took, there was no evidence of bony injury, and this man had a NEWS2 of 0. And how often, when you're duty doctor, do you get those calls from the paramedics saying, this man's somebody's fallen, is it okay to leave them? And you can see with the NEWS2 of 0, actually it was helpful because this man was physiologically stable, whereas if it had been 4, perhaps he could have had a chest infection and that might have made him fall. Okay, he could have had a stroke, but we have to trust the paramedics in that. But you can see that help. And I often find that it's useful when I'm seeing somebody with an infection like a sore throat, that actually I can write down that they've got a NEWS of kind of 0, 1, and that helps support my decision not to admit that patient. Oh, and I've just seen Simon's putting respiratory rate's the most important parameter, so I can see that in the chat. So do think about that one. Next slide, please. So NEWS2 can also be helpful when you really are dealing with very challenging situations. And for those of you who are local, this is Hallfield Prison. And this was shared by a nursing colleague who undertakes the routine assessment of newly arrived prisoners. And they had one man who was particularly agitated, and it was thought to be due to spice, which is often, a common thing when people are admitted with taking drugs. Eventually, they were able to examine him, and he had a NEWS2 of 6. And the nurse thought that it could be due to anxiety, as the prisoner had tachycardia and raised respiratory rate. So rechecked the observations at 30 minutes, and it remained at 6. So apparently, normally they don't strip prisoners off, but because the NEWS2 remained raised, the nurse involved stripped the man off, fully examined him, and found he had an infected groin secondary to injecting into his femoral vein. Diagnosis of possible sepsis made, and the man was admitted. And again, that's where I find the value is if you're not quite sure what's going on, think about NEWS2. It's not diagnostic of sepsis, but can it help you if something's not quite right? Next slide, please. And NEWS2 can also support our junior colleagues at raising concerns. We did, before COVID, we did quite a lot of work with the eating disorders unit at North Bristol. Sadly, we were going to undertake some work and COVID overtook us, so we didn't proceed on that. But talking to the managers there, NEWS2 is often raised on admission because the people who are eating less often have a low systolic blood pressure, low temperature and bradycardia. So it's important to know what's normal for that person. But in this case, the woman was transferred to the inpatient from the medical unit. And overnight she became unwell. And apparently the nurse in charge had only just qualified as a mental health nurse 3 months previously. So very junior colleague. But she took a full set of observations. The patient had a NEWS of 6, so she discussed with the medical team, and a transfer was arranged for the mental health unit over to the main hospital. The nurse became worried that this woman was deteriorating, retook the observations, and NEWS2 had risen to 9. So she was able to expedite the transfer, and the patient was found to have malnutrition, dehydration, and a low potassium. And I share this story because obviously it was a good outcome for the patient, but it was also supported that very junior colleague in raising concerns because she was able to give objective measurement of the reason she was worried. And she also protected that admitting team, because if something adverse had happened, would the physicians, would the admitting registrar have been blamed for not expediting the referral? So it was that really helpful way of team working that protected the patient. Next slide, please. And this was shared with me with Anne Pollyblanc, who I mentioned earlier, who's a colorectal surgeon. And this was a patient in her 40s with schizophrenia, so quite challenging mental health history, and a poor historian. She'd had a buttock abscess develop and had been reassured. And then she was seen by the GP on the Tuesday after a bank holiday weekend and was admitted buttock abscess NEWS2 5 query sepsis. And this is what I mean about the GP being able to alert the admitting team that there's something more going on. So the woman was treated with antibiotics and fluid and was in theatre within hours. And as Anne said, the usual pathway would have been the surgical hot clinic. But by the GP sharing the NEWS2 value of 5, Anne knew that something more had to be done. And it was that real value of the communication. Next slide, please. And there are also the what if moments. Most of these stories are the what if moments for others, but this is mine, or one of mine. And this was a young woman who was seen by a nurse practitioner in the morning surgery with a sore throat, and she had a NEWS2 of 3. And Jo safety netted the patient, but for some reason, and she's not sure why, she also gave the patient a review appointment with me a few hours later. And I said to her later, why did you do it? What was it that made you concerned about this woman? She had a NEWS2 of 3, and she couldn't articulate what it was, but something bothered her, and she knew that I wouldn't be upset with asking this patient to come again. And so the woman walked in the afternoon. Interestingly, in the morning she'd been by herself. In the afternoon she came in with her partner, which often I think indicates that people are more worried. And she looked absolutely fine. She was in her 20s, but she had a NEWS2 of 8. I was like, whoa. So I stopped and rechecked. Still a NEWS2 of 8. Tonsillar abscess wasn't a quinsy because the uvula hadn't moved. So the infection was probably, was kind of retro, it was at the back of the tonsil. Blue lighted her into the ED. The ambulance arrived within 10 minutes because I phoned them and said her NEWS had been 3 in the morning, and then it was now 8. She had tonsillar abscess. I pre-alerted the ED team, and she was in theatre within an hour of arrival at ED. And this is the moment for me thinking, if I hadn't measured her NEWS2, which I have realised that woman was so sick. And they talk about cryptic shock for people with sepsis, particularly if they're young, that they manage to maintain their cardiovascular functions, they look okay until they crash. And this is that moment you can't help but think about. And once you've had one of these what if moments, you can't not use NEWS. So I used to do a full set of observations for anybody with an infection because it was evidence of examination, and just in case there was a what if moment. Next slide, please. And then this is the other one, which I'm sure a lot of you will recognise. I've worked at both of the universities, but I worked at UE. This was an international student. English wasn't his first language. Cough and feeling unwell. Had a splenectomy following a road traffic accident. Not on antibiotics. No vaccinations. And he had signs of a respiratory infection and NEWS2 of 4. So I arranged an ambulance. Didn't make it high priority. And he was sitting asked the nurses to kind of keep an eye on him while we were waiting. And he was there for some time. You know what it's like waiting for ambulance transfer. Primary care is a place of safety. And the nurse just came to see me and went, Alison, I'm worried. This man looks like he's worse, and his NEWS was 4 when you put him outside my room. It's now a NEWS2 of 6. So we had, again, objective measure of deterioration. And how many of you have looked at those patients waiting outside your room for transfer thinking, are they sick? Are they not sick? Am I just being anxious? Is it because I've been waiting so long? And if it's NEWS2 have been forced, then you can think, oh, well, actually, they're still stable. but this was objective measure of deterioration. So I expedited the ambulance, and they were there within 10 or 15 minutes, put fluids up in the consulting room and took him away. And for me, that was really helpful. Again, it helped me support in my decision making. Next slide, please. And then this one came from John Caldwell, who's a GP in Liverpool. And as I say, these are all, once people use news, they can't not use it. And so that's why they then share the stories with me. And in fact, if any of you listening to this get a story afterwards, please let me know, because I like to share good practice that others have got. And again, John spoke about this woman who turned up in her 30s, usually fit and well, but turned up at 5 a.m. unwell. NEWS2 of 6, and they diagnosed pneumonia, although she didn't apparently look that sick. She collapsed in the ambulance, and her NEWS2 went up to 12. So obviously she was in the ambulance that collapsed. She was in the right place there, but they were able to pre-alert the ED. And Emma Redfern, who's a GP, who's an ED consultant at UHBW or BRI, says often for them it's a bit like the Where's Wally, who's sickest in the ambulance. And that allowed the ED colleagues to prioritise this woman, and she was transferred to ITU. So you can see it really can go quickly from 6 to 12. Next slide, please. So I gave a talk last year with Mark Luciani, who's a GP in Bath, Swindon and Wiltshire, and I thought I'd like to share some of his ideas of how to contextualise NEWS2, because they really echo with what I say. And first of all, it's that, that's odd. If it's high, what's going on? What's askew in this? What else is happening? You know, why is that respiratory rate up? Because I believe it can also be used in PEs. You know, what's going on with this patient? But then also what's normal for the patient? They're not just numbers. You know, what's normal for this patient in front of me? Like I mentioned earlier with the patients with long-term lung disease, do they always have low oxygen sats? And so he was saying that the value for him of the NEWS2 is it often paints a quick picture. You just have that quick idea, so it supports your clinical judgment, improves communication and visualises change over time. Next slide, please. So the baselines, I think, are really important, and it's what's normal for your patient. So for many years, in fact, over 10 years, I was the medical officer at Gloucester County Cricket Club, so worked in professional cricket. And one of the challenges was the teams would go away, often for a week, 10 days, playing matches against other counties. So perhaps in Durham or up in Manchester. So they'd be away for quite considerable times. And if they became unwell, I'd get a phone call from the physio. And there were quite a few examples in other teams where cricketers became really quite unwell, and it was the challenges of remote managing. So myself and Steve Griffin, the Gloucester physio, decided that we should do baseline news for everybody. And this is, you know, this was so I could work out the baselines. In fact, this is my son Will, who was an opening cricketer for opening batsman for Gloucester. And if you can see, Will, normal respiratory rate, normal oxygen sats. Obviously his temperature was okay, but his BP, systolic BP was 92. And in fact, working in universities, lots of women have low BPs when they come for their pill check. So what's normal for that patient? You know, 92 is not normal for a 90-year-old, but, you know, for a 19-year-old. And also his heart rate was 48. In fact, having checked Will for other times, sometimes his heart rate could be in the 30s. So Will has a normal baseline NEWS of 3. And I shared this at a workshop with Matanada Kim, who I mentioned earlier, who's National Clinical Director. And when I did it, one of the GPs commented and said, but if Will were to become unwell and his heart rate were to rise into the normal range, so 88, his NEWS2 would actually fall because he's actually within the normal range. So I hope that helps in some ways to think it's not just, you can't always ascribe actions to scores. You've got to look at what's right for that patient, which is why it's often useful to document their observations when they're actually physically well, or perhaps when they're coming for a pill check or another reason. Next slide, please. And I'm continuing that theme of not ascribing actions to scores. Something I feel very strongly is not all patients should be admitted, even if their NEWS2 is high. And this was shared to me with me by one of an advanced nurse practitioner. So it was a 93-year-old man living in a care home. He'd been unwell, and so GP visited, diagnosed a UTI and a NEWS2 of 3. Next day, he was much more unwell, and my colleague went to see him. She'd never met this man before, repeated his news, and it was an incomplete news because she didn't note down his level of consciousness, but the news 2 was 8. So had objective evidence of deterioration. His news was 3 one day, his news was 8 the next day. She also knew he had a DNA CPR in place, and so he'd made some decisions that actually he didn't want active intervention. And the family were adamant that the man wanted to die at home. And Sue said to me how it was really helpful because she'd never met him before, and she would have thought, well, yes, he's probably dying, but knowing it was 3 one day and 8 the next, again, gave her that objective evidence, which was really helpful in saying, yes, I think he is dying. He doesn't want admission, let's keep him here. So he stayed in the care home, surrounded by the carers who knew him, with his family around him. He died a few hours later with urosepsis on the death certificate. And I'm not advocating that we should be taking regular observations in people who are dying or the end of their lives, but Simon Stockley from the RCGP, who I've noticed is on this call, we were discussing it earlier today and saying, when News 2 is so helpful is when we don't know patients, when we walk in and we're expected to make a decision on somebody we've never met before, and how helpful it can be to have a one-off set of observations, which might help us with this. Next slide, please. So I've mentioned primary care quite a bit, and what's the position of the Royal College of GPs on this? And this was issued in 2020. And so basically the RCGP supports the use of physiological measurements in general practice setting for all patients at risk of deterioration, so taking full sets of observations. And the recommendation in 2020 was there should be more research evidence on the use of News 2 in primary care settings before the RCGP can absolutely recommend its widespread use. And I don't disagree with that. What I'm saying is that, yes, take full sets of observations. But for me as an individual clinician, News 2 can help support my clinical decision making and decide what I'm going to do with the patient. So what I'd like to do now is actually share some of the evidence as requested by the RCGP. And the first one, gosh, sorry, Lily is so good now, I'm not even saying next slide and she just goes on to it. Thanks, Lily. The first one was a qualitative review that was undertaken at the HSN by NHR ArcWest, looking at the use of news outcomes outside acute settings. And the first one was on the nurse was actually conveying the patient's condition, and before just saying they've got a tachycardia and they don't look well, but actually if you then can add on they've got a News 2 at 6, that really adds impact. Just as an explanation, if we put news, it's because some of these papers, some of the work was done before 2017. One of the GP colleagues said it's actually much easier to admit a patient if you share the News 2, again, because you've got that value. It is, they've got a lower respiratory tract infection and a News of 4, they've got a lower respiratory chest infection and News of 7. You can see the difference if you're getting the admission, how much it's helping you as a GP, whereas before it was like, how unwell do you think they are? And you'd be looking at them, well, I think they really look unwell, but it was always very judgmental, personal judgment. Oh, and if that's a question, please put it in the chat and we'll come back to it at the end. If it was just an inadvertent mic, that's absolutely fine. This, though, the last one is the bit that we were not expecting, and I believe has been the biggest change for my practice. It's that making a decision not to admit somebody or not to refer somebody, there's a lot of potential comeback. You can be criticised for for not admitting a patient. And one GP I spoke to years ago, I remember her saying, well, if I'm going to not sleep tonight because I'm worrying, I'm going to send the patient in. But if you can take a full set of news and show that when you saw that patient at 6 o'clock, they had a News 2 of 2 and you safety netted them, that can be really powerful evidence of a full and considered set of observations. You hope that the patient isn't going to deteriorate, but if they do deteriorate at 11, you can show what you did at 6. But also, if somebody else can access your system, they've got a measure of objective change. So it's basically, as this GP said, anything that covers you and helps protect you or back up your decision making is potentially useful. So I would really suggest, if you're like me, how I used to be before NEWS2, and you'd wake up at 10 or 11, you'd be thinking, oh my gosh, did that patient with that chest infection, did they just simply have a chest infection? Could they have pneumonia? Have I missed it? It can really help you prove what you've done. If that's the only thing you do today, think about it. That might be hopefully one of the most useful messages. Next slide, please. Some of the other concerns were that lots of people would have a NEWS2 of 5 in the community, and therefore that's why it would have limiting value, because they'd be triggering referrals and consideration of sepsis. And this, as you can see, large data sets looked at again by Lauren Scott from NHR Arc West. And looking in the ED, the top left, that actually, again, most patients had, even in the ED, most patients had a score of 2 or less. Similar in ambulance service, although slightly more with a score of 3 or more, but it's not high numbers. Again, in the community settings, but the Bristol community, that was pre-Corona. Again, a lot of patients have low NEWS, and this includes a lot of patients who've got COPD. So it's even though they're sick patients being seen in their homes, a lot have got low NEWS. And again, if you look at the baselines, that can help you. And the GPST is the GP support team. So they were the team admitting patients. So they've already been seen by the GPs. And as you can see there, far more had a NEWS of 5 or more. In fact, for 3 or more, and that's right, because they've been seen by the GP and triaged as being unwell. Yes, there are patients with a score of new or 0 or 1 and 2. I'm happy to answer questions on that, but we also know that patients with those scores, as I mentioned earlier with the Adrian Boyle paper, they still can die, and the physiological change may appear later. So again, clinical judgment's key. Next slide, please. And another concern is looking at saying, oh, it's not much use in older people. I mean, there are issues that if you're older, you might have a slightly slower physiological response. But Rob Barker and the team in the Northwest have done a lot of work in care homes. They looked at over 19,000 NEWS scores from older adults. And basically, the median NEWS was 2. So 2/3 of the patients have had a NEWS of 2 or less. So you can't, it's not appropriate to say just because you're old we can't use NEWS2. But again, what could be useful is knowing what's the baseline. When somebody's remitted to a care home, can you do the baseline NEWS? Perhaps, I'm just testing, could you repeat it every month, so that way you know what's happening. It also can give carers in the care home confidence to measure observations and share them with you if somebody's unwell. Just thinking, how many of those calls do you get? Mrs. Jones is unwell, she's off her legs. Could you visit? Do you do it? If you get Mrs. Jones is unwell, she's off her legs, her NEWS2 is normally 1 and now it's 4, gives you a really different decision making. Again, that's a discussion for another time, but you can see the value of using NEWS2 in care homes. Next slide, please. Oh, I've just seen, hi Joe. Joe Chambers, actually, I've just seen, do you know what effect use of antipyretics has? I think I wouldn't really worry that much about it, actually, Joe, because it's low temperature, and the temperature, I think, probably doesn't contribute that much. But perhaps what we should be doing is looking at pulse rate and respiratory rate and considering checking somebody at a later date, perhaps a bit later if you're seeing them. But again, it's getting that familiarity with the patients. I'm happy to answer more on that later. So we wanted to look at the association between NEWS in primary care and clinical outcomes. And so we looked at over 13,000 patients, again, Lauren from NHR Arc West. And these were the first NEWS when the GPs were arranging admission. And again, we found that higher NEWS values were associated with increased length of stay, increased ICU admissions, increase in sepsis, suspected and diagnosed. If you can see on the odds ratios on the right, look at the higher the NEWS, the greater the odds ratio of having sepsis. And the higher NEWS values, so the first one, when admission was being arranged, the higher mortality. Interestingly, if there wasn't a NEWS value given at admission, most clinical outcomes were comparable to patients with a NEWS2 of 3 or 4. And we kind of have discussed that, whether that's partly because clinical acuity wasn't being measured, whether that meant that the track and trigger score was starting in hospital, and you lost the value of knowing what was happening in the community before they were admitted. Next slide, please. I apologise for this slide in some ways because it's slightly complex, but I thought it was still worth sharing because there's no rule in, rule out for making diagnosis of sepsis. Matt and Arda Kim has pulled together a data set to look at suspicion of sepsis. And what is shown here is an SPC, a statistical process chart, which looks at changes within the system and has upper and lower control limits. So the green and the red is up there, upper and lower. And the top kind of grey hash line is what's happening in the mortality from suspicion of sepsis across all the systems in England. And in the blue line below is the mortality from suspicion of sepsis in the west of England. And you can see there's a break, which I've circled in red, and that's known as a special cause variation. Something different was happening in the west of England. As the Patient Safety Measurement Unit, which was then part of NHS England, attributed this fall in mortality to a change in clinical practice and the use of news in the community and across systems in the southwest, in the west of England. So it needed much more work, and we planned to actually repeat it in other systems by raising awareness of NEWS2 prior to COVID. But then, of course, COVID's come and we hadn't taken it further. But there's definitely, there's the change in the system with the use of news as a common language. Next slide, please. And I thought I'd just share this one, which was part of the work on the SPC, because one of the other concerns is that using NEWS2 increases admissions. As I've said earlier, that hasn't happened for me. And if you look at the west of England on this, we're kind of towards the bottom in pink. Actually, there was no greater increase than other systems. And I like to think that what NEWS2 does, it helps you better discriminate between who's sick and actually who doesn't need to be admitted. Next slide, please. So if you want to know more about this, a number of colleagues wrote a review on the use of NEWS2 in out-of-hospital settings, the ambulance and the ED in the RCP's Clinical Medical Journal in December 22. And our feelings very much is that NEWS2, as I've highlighted, can enhance the community response to acute illness by using this common language. And something else that I feel quite strongly is that one of the advantages of NEWS2 in community settings is it's not disease specific. There may be some great tools like decaf for pneumonia or for specific diseases, but we're having an undifferentiated population. And as I shared with that patient who might have had sepsis, who might have had obstruction, if they've got a high NEWS, they need to go into hospital. That's our priority. And so therefore NEWS2 to me is very practical in the way it can support clinical practice. Next slide, please. And we made a number of comments in this review, but one was very much it doesn't override, that using NEWS2 doesn't override existing pathways for specific conditions. It has to be used alongside clinical judgment. It's not the be all and end all, it just helps you. It's another tool in your toolbox. And again, Matt and Arda Kim suggest that using news could enable better downstream care to be better calibrated to risk. So by starting the track and trigger element before the patient comes into hospital, it helps you know what's happening. Next slide, please. So having just said that NEWS2 is non-specific, not disease specific, certainly I think there's much more potential for its use. And this is a paper we did during COVID. And we found that basically the higher the news, the poorer the outcomes for patients with COVID. And this would look at the first electronic NEWS2 on arrival in hospital. Having said that, patients could still die if they were admitted with a score of a NEWS2 of 0 to 2. So clinical judgment is important. And I think quite often patients know they're unwell, or clinicians know they're unwell before the physiological changes become more apparent. But you can see there's a strong relationship between NEWS2 and outcomes. Next slide, please. And as I mentioned earlier, I'm also a clinical coordinator at NC Pod. And so every time I see the reports, I can't help but see them through the lens of looking at NEWS2. And this one on heart failure, over 200 patients where NEWS2 was used, and 55% of them patients had a NEWS2 of 5 or more. So where's is this potential for us to be looking at acute deterioration in heart failure? Can NEWS2 help support decisions, identify who's at risk? And something else I always wonder about is if somebody's got long-term heart failure, could we start tracking respiratory rate, pulse rate? Perhaps pulse rate's a bit difficult because of beta blockers, but can the slight increase in respiratory rate start help us in predicting if somebody's going to die in the next 6 months to a year, and we should be having those advanced care planning decisions, something to discuss for the future. Next slide, please. And then this was a study we published in December 22. I was one of the coordinators on it's called Consolidation Required, and we looked at NEWS2, looked at community-acquired pneumonia, particularly NEWS2, and again, the higher the news, the poorer the outcomes. And you can see that if a patient had a NEWS2 of 7 or greater, they had a 50% mortality. Now, these are small numbers and it needs much more work. But again, you can see the value of supporting your decision making. There's also some music on with CURB 65. I've got some concerns on CURB 65, but that's very much pneumonia related. And again, the value of NEWS2 is it's kind of not disease specific. Next slide, please. So I've started asking questions, looking for more research, and one of the areas I'd like to highlight is the secure data environment. And Rachel Denham from Population Health at Bristol University, I think, is on this call. I think I saw her join earlier. And I've been working with Rachel to look at this, because what happens, oh, brilliant, great, I just saw Rachel there, it's great you're here. If anybody wants to ask any questions, and the great value of the work Rachel's doing is linking data sets in primary care, acute care, and the ambulance to start asking these questions on the very big data sets. And so what we're looking at is the pneumonia and NEWS2, and actually, can we start answering those questions? And if we could use it for pneumonia, can we do it for PEs? Similar things, you know, pulse goes up, respiratory rate goes up, oxygen sats go down. Can we start informing decision making? We've got some, and we're doing that work. We're starting to kind of test the protocols, and Rachel's just got approval for this to be a priority project for the next year. Next slide, please. So very quickly, if you're going to ask your HCA colleagues to take observations, could you know, these are some videos that can help share the learning and actually how to take the observations and how to record them. We've had over 1.9 million views. You're welcome to share them. They were co-produced with a whole group of people, and so they're very popular. Lots of nurses, Matt and Kim, who I've mentioned before, we all developed this. Supporting the Restore2 tool, if you know of it. Next slide, please. And I mentioned earlier the value of care home staff taking observations. So if you want to share these videos with care home staff, then feel free to do so. They don't mention NEWS2, but again, it's simple ways of actually how to measure respiratory rate. So going back to that question I had earlier of, you know, the phone call when somebody in the care home's unwell, how can it help you if somebody's able to share observations? Somebody criticised me and said, oh, but you're asking carers to make decisions. We're not, we're just asking them to give you more information so you can make the decision. Next slide, please. So I hope that's really helpful. Think about it when you see the patient, just recording the observations, even if you don't actually use NEWS2. Record the observations so you've got a record there, so that, you know, it's coded, so it's there for other people. But I would like to suggest you think about using NEWS2, how it can support your clinical judgment, how it can provide evidence that you've examined that patient properly. If something goes wrong and you have to defend what you've done, think about that. How can you improve communication across systems and improve outcomes from your patients? And also, and probably most important for me, how can you avoid those what if moments? What could I have done to enable me not to have missed that patient who's sick, who didn't appear to be sick? So thank you. A quick overview. Any questions? Lily, should we stop sharing? There are a few coming through in the chat, which I've seen, but if anybody wants to put their hands up, I'm happy to take questions. But I can also add, I can see Jackie Yule's one on chemotherapy. And Jackie, that was in fact some work that we were thinking of doing just before COVID. I think it was Adam Dangmore from UHBW, because what we were wanting to do was whether we could support patients to measure their observations. So if they become unwell, they can then again, if they're on chemo, they can phone the oncologist and say, I feel unwell, share the observations, and then that can help support the oncology colleagues. Do they see that patient within a couple of hours, which is the usual practice? But if they've got high news, they could then escalate and get with an ambulance. That we have had patients who've been doing that and taking their own measurements, and we'd love to have done it. We were going to do it, but then COVID happened. I can see huge potential. And again, Rachel's on the call, and that could be something that we could look at patients on chemo with those big data sets. Does that answer your question?
Yes, thank you very much. I mean, personal as well. My dad's having chemo, and I was thinking, how do I identify?
Yeah.
How do I get him to work out? Because he doesn't tell me.
And so in fact, what I did before COVID, I mean, I didn't know how much I was involved in the COVID response. I became a regional clinical lead. It's all a bit learning curve. I've got a big family. I got everybody to take pulse oximetry, BP cuffs, and thermometers. And so when they were unwell, they phoned me. Ironically, my mum, who'd had lots of funny turns, in April 2020, phoned me up and said, Alison, my pulse is 20 and I don't feel very good. Do you know why? And we now found out she had tachybrady syndrome. So she was evidently bradycardic. She became tachycardic. They admitted her, gave her bisoprolol, which I wasn't that keen on, but luckily they kept her in because she arrested in the night on CCU. Yeah, she was thumped by the nurse and she had a pacemaker fitted. And it was the pulse oximeter. So it does make me wonder, if you've got somebody with funny turns, should we be giving them pulse oximeters? A slight aside.
Might go and get one.
And I think it's worth it. It doesn't take very much. Share it with your family. So yes, I didn't expect to diagnose tachybrady for mum, but I hope that's been helpful. Any other questions?
There's one there about pews, which I routinely use.
Yeah, it's coming. Thanks, Lily. Yeah, so I should have said that NEWS is basically 16 and over. Pews is coming in, or Spot. The single. Oh gosh, it's Damien Rowland is developing that. The problem is often you can't do blood pressures. But for me as a GP, what I used to do was respiratory rate and pulse rate for kids. And that's the key, is again, take the observations. And I know one of the letters I got of thanks was a young baby came in, abnormal observations, couldn't work out what it was. I was in out of hours by the time she arrived in the children's. She'd got obvious meningococcal sepsis. She'd got the kind of the non-blanching rash. And it was the observations that made me realise. So that's where I would say, even if you're not using a full pews, because we can't do blood pressures, take full sets of observations. It's evidence of what you're doing. Thanks, Joe. I just think, yes. Oh, Simon asking about access to paediatric oximeters. Any other questions at all that I've got? Oh, yeah, it says, hi, Simon. Claire, could we arrange a chat to discuss escalation procedures in reablement? Yeah, I mean, I'm happy to have a chat about looking at NEWS in wider settings, because I don't quite know where you work, Claire, but I can just see the value of knowing what's normal for that patient is actually key to a lot of that work. And so the reason Simon's come on is the RCGP. There were a group of us. We're looking at that with the RCP, because the statement was written in 2020 after a meeting in 2019, and it's really changed since then. Because actually I can see, as I alluded to earlier, the use of NEWS in PEs, because actually there's the PESI score, the PE severity index score, and it's almost maps to NEWS2. So if you've got somebody who's got shorter breath and hemoptysis, is it a PE? Is it pneumonia? Well, actually I don't know, but they've got a high NEWS2, send them in. Yes, actually, Jackie, Serona community teams, that's the kind of the value we can see for the HCAs, because again, if they're going out, they can take full sets of observations, then they communicate with the hub. And something Simon and I were talking about today is particularly in London, they're now having acute care hubs, which are staffed by allied health professionals who are taking responsibility for seeing patients, but the GPs carry the clinical responsibility for patients they're not seeing. And something that Simon and I were discussing is, should those clinicians be taking full sets of observations? And I'm looking at Lily as a paramedic, because you're the kind of person, no criticism of you, but if you're discussing the patient with me, how much more helpful is it if you can share the NEWS too? And it can protect the allied health professional, who I think people don't realise the challenge of seeing the undifferentiated sick patient in the community. I mean, you, Lily, as a paramedic, it must be such a challenge for you.
Yeah, and I think it's especially within it's recommended for all patients when you're working on the ambulance service,
Yeah.
and it automatically calculates. But then when you're working in these environments where it's kind of clinical decision, actually it's all about safety netting. You pulled on that point, is that it's those patients you're not omitting, but you don't want to worry about them. And it's really good for it's good for you to then demonstrate that at that point in time, then you saw that patient, they presented like this, and you can safety net. And if they
Yeah.
present a lot later and have a raised news score, it really does cover you, because that's the issue, isn't it, as well? It's covering yourself as well.
And also, if they have the same, they represent, they've got the same news too, then
Yeah.
actually that's helpful for follow-up
Yeah.
clinician. Simon, thank you.
Yeah, hello everyone. I'm Simon Stockley. I'm the former clinical champion for the RCGP for sepsis, and was thinking today when I first came across early warning scores, and it was probably 2006. So one of the things that I find very useful about early warning scores and just recognizing and weighting physiology is preventing cognitive dissonance. We've all been in the situation where we're going to see a patient and we don't think it's going to be important. It's going to make us late for something else that is important, be that school sports day, taking your mum to the hospital. We've all been in that position, and we know that those are the times when good people make mistakes. And I've been in that situation, and it is actually the reliance on physiology that has stopped me making a somewhat judgmental decision on somebody who on first looking has been unwell for just a few hours with a diarrheal illness and a bit of bellyache, and is just a bit over dramatic. And if she doesn't mind stopping hyperventilating and holding still, I'm sure I'll be able to feel this radial pulse, which I can't, of course. And then I'd better do her blood pressure. Oh, that's a bit low, but she's quite young, and that respiratory rate is actually 28, and she hasn't calmed down, and the news score is now 7. So I'm not really going to call this gastroenteritis anymore.
Thanks, Simon. And
When was your last period? 6 weeks ago. Could you be pregnant? Yes, but I didn't like to tell my mum who found you. Oh, so could you have an ectopic pregnancy? Which of course you did.
And thanks, and that's, I'm aware of the time, and so thank you. And that's exactly why the use, it's not disease specific, and I've used it loads for patients with a learning disability, for the similar thing for people who can't give a history. So I hope that's been really helpful, Lily. I know you want to finish on time, so I'm going to